Good morning again. How you doing? Great session you just came from? Yeah, learned a lot, huh? So thanks for coming to the nurse session. This morning, again, I'd like to introduce Chris Hendricks, and I have so enjoyed working with Chris. Chris is from Boulder, and he is the educator in Boulder, number one, and Boulder was one of our pilot hospitals. So Chris not only has a background, he is the educator for the clinical educator for Boulder Community, but he is also the educator for the Emergency Nurses Association. So he has a double whammy for you. He has lots of information about being a pilot hospital, can share that knowledge, but also as an expert for the Emergency Nurses Association. And I'll tell you, when we partnered with these partners that Dawn and Janet and I spoke about, it was really important to have ED nurses training ED nurses. I'm a nurse, and I could certainly go in and do all this work and train nurses, but having emergency nurses training emergency department nurses, critical, just like it was important to have emergency physicians training emergency physicians. So without further ado, I would like to turn it over to Chris. So a nice round of applause for Chris,
Okay.
please. Thank you.
Thank you. Thank you. Good morning. Welcome, and thank you so much for your interest in the ALTO project. I'd like to get a sense of who we have in the room. We're not going to go around everyone, but do we have ED managers here? If you could just raise your hand. Educators? A couple. Any just staff nurses here as well? Okay, great. Thanks for coming. As Diane said, I'm the educator at Boulder Community Hospital. I also work in the ER. My educator's a .6, so I do a shift a week in the ER, and it really helps me stay in touch with in the trenches, as it were. So I really get to see these modalities at work. And as Dr. Stater alluded to, this is a big culture change for everybody, and I want all of you to raise your hand if you have questions. I know you're probably a little skeptical about some aspects of this program, as I was when I first heard about it a little over a year ago. And I've sort of drank the Kool-Aid, as it were, and really come along to really supporting this program. So culture is super, super important, as Dr. Stater said. The stigma attached to addiction affects all of us, and I know in my own practice, I started out as an EMT and paramedic 20 years ago. Those are my least favorite patients. Somebody who's not breathing in the back alley somewhere. But I've come to realize a lot through this program that they have a sickness, and we should have some compassion for them. I just want to tell a little story. Not too long ago, I had a patient come in complaining of alcohol abuse. He wanted to get into detox, and his family was in the room, and he was making comments like, "Oh, I screwed up again. I suck." And I said, addiction is a disease. And he looked at me with these eyes, and he's like, "Do you really think that?" And I was like, "Yes." And I could tell all the family members were like, starting to understand just by that statement a little bit that this may not be his fault entirely. So I urge you to keep that in mind as you're progressing in this program, you're selling this program, that it does work. But I think it also has to do with how we relate to our patients. And as nurses, we're doing a lot of the hand-holding and the education and discussing with patients and trying to change their paradigm as well. So we're going to talk a lot more in detail about that. Any questions so far? All right. I have nothing to disclose. I'm also a flight nurse in the Cheyenne Air National Guard, and I've had the opportunity to see the nerve blocks that are used in the military pretty commonly, and I really hope that that can move forward and into more common practice in the civilian world. For example, if someone has a femur fracture, they'll put a PCA catheter right into the femoral nerve, and so that soldier can just push the button, and they have almost complete pain control from a fractured femur, and they don't need narcotics as a result. I realize that's a big step from where we are today, We don't have anesthesia in the ER standing by to put in these catheters, but they really do work. And the trigger point injections we're going to talk about are sort of, I would call that sort of that part of a light procedure. These are the objectives we're going to talk about today. I'm not going to read this whole thing. This is the part where I tell you what I'm about to tell you. So, this document, this ACEP, if you haven't seen it, I highly recommend you go and get a copy from the CHA website. It details a lot of the science behind it, and it has some really, really good information. I didn't read this right away when we started our pilot at Boulder, but it gave me a lot of insight as to the background, and it was really good information. As Dr. Stater said, we're going to try and use non-opioids first. And I know what you're probably thinking, that, hey, we push a lot of opioids, and if I if I go into the ER with a femur fracture, I kind of want narcotics. We just want to change the paradigm that we want to start with the altos, but sometimes you're going to go right to narcotics. If you have somebody screaming in pain from a horrible injury, right, they're going to get narcotics. That's okay. But they don't always have to, and they don't always have to go home with a prescription of 100 Percocets either. I know I've seen the providers I work with are giving much, much fewer numbers of narcotics when they do. And just like Dr. Stater said, he's going to give them a prescription for maybe 10 oxys, and maybe give them a prescription for ibuprofen as well, and counsel them to taper from one to the next. So our discharge, our instructions are going to be reinforcing to that. I know I've taken calls from patients who complain when they get to the pharmacy and they realize they've only gotten 5 Percocets when they're used to getting 25. So our patients' perceptions are, they know kind of the way the system and the way we've been doing it. So we really need to be forthright in telling them, hey, we're doing this, we're changing our practice because of the opioid epidemic and the overdoses. And it's really important that we keep them in the loop, as it were. Am I standing in your way? Are you okay? There, okay. Opioids are considered rescue. And this multimodal we're going to talk a lot more about as we go. And these are the 5 pathways that most of our patients are complaining of pains, the pain that fits into these categories. And if you think about it, right, this one magic bullet of opioids treating all conditions is really counterintuitive, right? We should be treating the cause of where this pain is coming from, and that's what this is all about. CHA has a nice poster, and if you all have your handouts, I hope, that explain the kind of the drug groups that go with each of these complaints. All right, so we're going to educate our patients. As it said, opioids will be second line, and sometimes you're going to go right there, as I said, but much, much less. As you saw the numbers, we're giving much less total doses of narcotics. I know in my ER, we had a very strong standing order set for the nurses, that nurses would frequently go ahead and order labs, x-ray, and 2 of morphine or milligram of Dilaudid. They removed all the narcotics from the nursing standing order sets. So we can order the altos, but the narcotics are now only provider-driven. And if we have that patient, I'll go find the provider and I'll say, hey, I really think we should give them some narcotics. And sometimes the provider will want to see them first. As I'm going to talk about further, some of the providers are what we call early adopters. Some are sort of mid-adopters. So there's a lot of variability I've found in the providers and how much buy-in they have to this. But I think with our support, we can just make that even better and kind of loop in the late adopters, as it were. Discussing realistic pain management goals is super important. We should never be saying to our patients, we're going to make your pain go away. I think this has been a sort of accepted thing in our society that nobody should ever have pain or be uncomfortable. I think we need to be realistic. We're going to talk about some language to kind of scripting that will help the nurses do that. Just to make the patient more comfortable, we're going to reduce your pain, but I would never promise to make it go away. I think that can be an unrealistic expectation. And a lot of times with these altos, you will actually remove all pain. The headache pathway is terrific. And we're going to talk about, and one of the things I counsel my patients about opioids is when they ask for an opioid, I really stress how addictive they are, how the adverse side effects, they can be dangerous, cause constipation. I had a friend that was hospitalized for a shoulder injury, and he had the worst constipation. He said that was worse than the injury itself. It took him a week to recover from that alone. This sort of approach is the, stands for, oh boy, alternate pathways. I'm going to use my notes. Channels, enzymes, and receptors, which I think is on the next slide, yes. Okay, so this is just a picture of a neural pathway at the nerve junction. And if you look at all the different enzymes and structure of that, if we could interrupt any part of that transmission of that nerve impulse is where we're going to get pain relief. So some examples, we all know lidocaine is a sodium channel blocker. So that's just one avenue of attacking a nerve, right? Electrical carrying nerves are especially susceptible to lidocaine, which is why it works so well. Enzymes, like in NSAIDs, we're going to reduce the inflammation, the cytokines, the immune system response, which causes inflammation and pain. And then we're going to do, we have these direct receptor blockers. As you know, there's many, many receptors, thousands in our bodies. Opioids just kind of attack the one, but there's all these other receptors that we can attack as well to interrupt that pain response. You guys have any questions on this part? When you put these together, you get synergism. You get multiple drugs working in multiple ways. You get increased pain control rather than just that one. Whoops, I'm sorry, I thought there was a laser in there. Instead of just the opioids. Good so far? Okay. All right, so this is just an example of headache approach. Decadron is going to reduce the inflammation. The promethazine is going to hit some receptor sites. If you look at your headache algorithm, there's a liter of fluid, which you probably already do. Ketamine can be useful. And then this lidocaine trigger point injections we're going to talk about. Does everybody know what a trigger point? Who doesn't know what a trigger point injection is? Everybody knows? Oh, great. I'd like to see the physicians using them more. It really depends on physician comfort and physician training as to how much they're using them. I know Dr. Stater in a different presentation, they're using them pretty extensively at Swedish. If you want one, that's where I would go. And they had a patient with just intractable back pain, and he would come in and ask for a specific physician for a specific trigger point. He's like, I want that trigger thing. So it's really effective in many, and in headaches, they're going to do a trigger point at the back of the neck into these muscles, and if it's a tension headache, that can really be effective. Just some more details on lidocaine. I grew up in a time when we used to give it all the time for cardiac. It sort of went away, and now people might be a little scared of using it or not as comfortable with using it. We're going to be using it at relatively low doses. This 1.5 milligrams per kilogram is about half of the total cardiac dose, and is totally safe in the non-cardiac patient. They may or may not need to be on the monitor. Your policy will have to be driven to whether the nurses need to put that patient on a cardiac monitor. If they have a cardiac history, I would say absolutely yes. But those are the kind of questions that you can, as you're working on your policy changes, you can approach the CHA with, and we can give you a good answer on that. It's good at musculoskeletal pain, especially right in the pain, right? Nerve block, finger block, wrist block. I'm sure we've all seen that. It's good for migraines. The renal colic, I think, is where lidocaine really, really soars. And if you think about the reason why, is because that drug is cleared through your kidneys. So you're basically pouring lidocaine right down your tubules, right where that injury is. So I think that's pretty cool. It is quite effective. Lidocaine patches are good for pain. It's close to the surface. We use 5% is the prescription amount, but you can buy 4% lidocaine patches in your pharmacy. and I recommend, and I tried one after I learned about this, and hey, it works. You know, I had a back strain, and I put it on there, and it does actually work. So tell the patients if they don't want to fill a prescription, they can just go buy them over the counter if their insurance isn't going to really cover it. All right, any questions on lidocaine? All righty. Trigger point injections. This was kind of new to me. It's just injecting lidocaine, or you can use bupivacaine directly into muscle or nerve junctions. On the right here, you just see all the host of places that you can do it, and that's just in the back. Okay, you've got nerve junctions obviously everywhere. They can be used in the extremities as well. The physician will just direct the lidocaine or bupivacaine directly in. Really, the only bad side effects might be infection, hematoma, arterial injection, or pneumothorax if they go a little too deep into the chest or the back. But it's really effective on torticollis and all sorts of different pain syndromes. So where nursing comes into that, I think, is you remind the physician, hey, what about a trigger point injection? Hopefully, I wish that our physicians had received more training in that particular thing. If you find that you think you want to use that more, you can approach CHA and maybe Dr. Stater or somebody can do more training. They got a brief overview of it, and I don't think they realize how efficacious it actually can be. Because I asked for it, and a lot of the physicians are like, well, I don't have time, or I'm not comfortable. There's not much we can do about that except be an advocate for the procedure. Any questions on trigger point injections? Okay. Ketamine. So, anybody scared of ketamine? Like, get a big, like, woo? Yeah. We had that, everyone had that reaction. It's like, oh my God, this is a conscious sedation medication. We're going to be killing our patients. Not true. The dose that you're going to be using is much, much lower. 0.2 milligrams per kilogram, right, in a 70K. I don't know, who wants to do the math? It's less than 20 milligrams total. And some physicians will use 0.1. It works. It works great for pain. And you don't get all those psychotropic side effects from low doses. It's sort of like dopamine. It has different effects with the different dosages. And it can be given intranasal, so it's great for kids. If you have a kid with a fracture, right, you can just give them a little intranasal ketamine. Yes. Wait, can you wait for the mic? Where's the mic? Well, they want to get it for the video too, I think, so.
So on the ketamine, I work at a really small rural hospital. So our ketamine's in a vial that we draw up. So if you give it intranasally, is it the same ketamine that I'm drawing up out of that vial?
Well, there's a couple different, I'm not a pharmacist, but it comes in a couple different concentrations.
Okay.
You need the higher dose, which is this one here, this pictured would not be enough to give 50.
Okay.
There's I think 100, I think it says it right here. Yeah, 100. There is 100 milligram in 1 ml.
Okay, and you just put an atomizer on that and
Yep.
do it nasally? Okay.
Yeah, and what I teach is that you should increase the volume to 1 ml for an adult. So if you're going to give them 50 milligrams, so it should be half an ml, you just draw up some saline with it to give it enough volume. Because if you try to intranasally squirt too little, it's not going to be effective. So, and in a kid too, I would probably bring it up to 1 ml and then split it over two nares.
Okay.
But you're not going to give a kid 50, but you would dilute it to what
you needed it to do that 1 ml.
Yeah, but you would just need to make sure you have the right concentration.
Okay.
So great question. Thank you. So ketamine, it's not scary. And one great use of ketamine, I had a patient not too long ago who came from the jail. Of course, he wants narcotics first. I can't remember he had an injury, I think. And of course, what is the physician going to, he's not going to give this guy narcotics at all. But we gave him 10 milligrams of ketamine. It relieved his pain. Right, we didn't have to worry that we were enabling his seeking behavior or whatever, and it worked terrific. And I think everyone felt good about that because I don't want to get to that. Anyway, benign and low doses. You do want to have caution with somebody with severe PTSD. I guess you would just evaluate the patient and talk with them over the possibility of them having some sort of psychotropic reaction to it. And this is a great drug to use in place of an opioid when you have an acute injury like a dislocation, a fracture, multi-trauma. You guys have questions on that? It can be given as a drip as well if they're going upstairs to the ICU. And our ICU already has a protocol for ketamine drip use, so that would be a good place for that patient to go. So these are some alternatives, Altos, Toradol. There's been study that 30 milligrams is not any more effective than 15 milligrams. I think after a year of coaching my physicians, they finally started ordering 15, right? They always think more is better. And 15 does work. And I don't know the science. I'd have to get back to you, but Dr. Stater has assured me that there's been studies that there's no difference between 15 and 30, so there's no reason to give 30. You guys probably already know, you guys use it for renal pain, right? Headaches. It works really well for those things. Haldol, low dose, 2.5 to 5, is really good for headaches and abdominal pain. Kind of off-label use, and it also treats some of the anxiety that comes with pain. How many of our patients will get a half a milligram of Ativan to go with a milligram of Dilaudid because they're so worked up? Well, maybe we should use Haldol instead. It does have a little bit of QT effect, elongation, and I know in the there was one patient that went into torsades from after Haldol administration, but there were some other precipitating factors. Her potassium was low. She didn't disclose she had a cardiac history and so on. If you have that patient you're a little concerned about, do the 2.5, and you'll probably be fine. It's also good for this cannabinoid-induced hyperemesis, right? And who's seen that, right? This is Colorado. Yeah, got a little bit of that going on. So this works well, and if you're going to make a nausea cocktail, right, you can include some Haldol into that. Bentyl, terrific drug for abdominal pain. It's a smooth muscle relaxer. It cuts down on a lot of the spasming of the intestine. It's got to be given IM or PO. It has a high incidence of thrombophlebitis if you give it IV, so that would be definitely a drug error. We have another picture of the vial, and it actually says for IM only on it. It's kind of this part of the writing that you can't see. So just make sure that's part of any education that you do. I mean, this is not a new drug, right? But we might be using it more. All right, I'm going to move on from that. These are, again, just another host of Altos. The Reglan and dexamethasone for headache work really good. The valproate is a GABA receptor that works at the spinal cord to modulate pain. DDAVP, I don't know the mechanism, but actually is good on renal pain as well. I don't know the pharmacology of how that works, but I was assured by a pharmacist that it's actually pretty good for renal pain. Nitrous oxide, we used to use years ago, and then it went away. Why did it go away? Because it kept disappearing somehow, mysteriously. It has a high potential for abuse. We've started using it at my hospital in L&D during labor, and it's very effective. It's very successful. The patient has to sign a contract that nobody will touch the machine. They will self-administer only. And if any of their family members is seen kind of looking at the machine, they take it away. We don't have it back in the ER yet. I'm hoping we will. It's excellent for wound care or short procedures like a relocation of a finger or something. The patient just holds it on their face, and when they get too much, what happens? It falls off their face. And the recovery is, just a couple minutes, has a very short half-life. I've been advocating for our director to buy a new machine, and I think it might be in our next year's budget. So I'm hopeful that we'll get back to that. But it's really good for short, painful. You could even use it for an IV start in a kid or all sorts of things. But this high potential for abuse, the way we control that is The machine has a valve on it, and with a little lock, and you remove the valve, goes in the Omnicell or Pyxis, and so when the patient needs it, you take it out under their name, you put it on the machine works. When you're done, you put it back in the Omnicell or Pyxis so that no one can sneak into that room and use the machine when it's not in use. And then NSAIDs and APAP, super effective. We're giving more and more Tylenol. It really works. It's a great first start for someone who's got pain. It's moderate, and kind of just take it from there. As Dr. Stater said, we're seeing declining ibuprofen use as we give Toradol more, right? Any questions on all of that? Yes, please. Mike? Well, you don't have to, but it would help us out. Thank you.
We need it for the recording.
So on all those meds, like they're designated for certain diagnoses, but can you mix them?
Well, of course.
Because like we have a really chronic renal colic patient who's very difficult. And so we tried the lidocaine drip on her with no effect. And we did it multiple times and nothing. So I was wondering like if like he said before, treating the psychodriven pain, like if we added Haldol to that mix, so you can do that?
Of course. Well, this
Okay.
is all provider
Well, yes.
driven. So
exactly.
they can do whatever they want.
Okay.
These are just suggested pathways that's been found to be effective.
Okay.
So you can mix and match, of course.
Okay.
And it's great to suggest to the provider, hey, let's try 2.5 of Haldol. And they might be like, oh, hey, great idea. I don't know.
So perfect. Thanks.
Great question. Thank you.
Thank you.
Any other questions? I do that a lot in my ER. Hey, how about, as you can probably tell. And again, just to reinforce that opioids are the last resort, not the first option. This is just a paradigm shift that we want you to start thinking about. This is not an absolute rule, obviously. Okay, so these are some of the groupings that you have in front of you. I'm not going to go through all of this. But just look at, this makes sense if you look at the first line therapy. Liter of fluid, most of our headache patients are probably getting that. Oxygen as well. Toradol 15, Reglan, Decadron. That'd be a nice first start for the headache and just see how they do. If they're intractable after an hour or two, then maybe they'll get a whiff of a narcotic, maybe not. But you'll find a lot of your patients, especially if you're selling them on this therapy, they're going to have a lot of relief. And this is probably one of the most effective, in my experience, pathways is the headache one. There's just a new drug. You guys know about this new drug that was just approved by the FDA for migraines. It's supposed to be a game changer. Hopefully we'll see less patients coming in with that complaint in the first place. Trigger point injection, if it's a tension component to it. And then at the bottom you see you can add some Valium or lidocaine right to the surface of their neck. All right, musculoskeletal, we obviously treat tons and tons of this. Again, APAP right off the front. Cyclobenzaprine is good, gabapentin, and then the lidocaine patches. Anybody using the lidocaine patches? Who's got them in their formulary? Just not very many. Okay. Well, hopefully you'll be seeing them, and they do work especially if the injury is close to the surface. Ketamine, 50 milligrams intranasal or IV. That dose is 0.2 milligrams per kilogram. And ketamine, Toradol, Decadron, Valium, all very effective. And the Valium is a narcotic, but it's much less addictive and pretty effective. Any questions? The renal colic pathway. Tylenol, Toradol, and a liter of saline. I'm sure a lot of you guys were doing this. We were doing this kind of before. And then the lidocaine drip. I was told by a pharmacist that in their study at MCR, about 50% of the patients get good relief from the lidocaine and about 50% don't. Now, I'm not sure. They didn't do a cause analysis as to why. It could just be the size of the stone, or it might be certain, if a tubule is blocked, that might be the kind of pain. It doesn't work well with lidocaine. I don't know. I'm just guessing. But, it's not guaranteed to work, let's just say. It's a good step, and it works often. but it may not entirely work. And as I said before, the DDAVP does have some numbing effect on the renal tubules, so that would be a good drug to try. Again, suggest it to the physician. Any questions? Chronic abdominal pain, right? How much of this that we see? I think 40% of all ER patients complain of abdominal pain. These work great. Reglan, the compazine, Benadryl, dicyclamine, very, very effective. It does kind of depend on their history. A lot of these patients are on a lot of narcotics. That may be the therapy that they expect. The way I would sell it is I would say we're trying some new therapies and let's just see how this works, rather than just having them say, I want my 6 of morphine right off the bat. And then you can always go to ketamine, which is very good for pain relief and not a narcotic. Yay. Obviously, we see a lot of these. Tylenol, ketamine, nitrous oxide, again, super effective. Is anybody here using it? Does anybody have it? I'm hoping we're going to, oh, great. What's your protocol? Use it for this type of injury? Okay.
Can you repeat that? Sorry.
We have it for our pediatric population.
And what do you use it for in pediatrics?
IV starts, any kind of fracture, just really even anxiety, we use it for them.
Great. Where are you? What hospital are you with?
At North Suburban Medical Center.
Oh, North Suburban. Okay, terrific. Yeah, well, great. And you find it to be effective. Yeah, I think it's terrific. So please, directors, any directors here, budget for a nitrous oxide machine, please. Yes.
I do have to add on the with extremity fractures. About 2.5 months ago, I had a trimalleolar fracture on my ankle, and I got ketamine in there. And I had just prior to that gotten some Dilaudid and some fentanyl, and ketamine was what really knocked the edge of it off for me before they reduced it. So
Great. Well, thanks for that.
I was sold when they gave it to me. I was a little wary when they went into it, but definitely sold on it.
You don't know the dose that they gave you, do you?
I wasn't really that focused.
I'm sure you weren't.
So, but yeah, I can't remember.
Okay. Where did you get that treatment?
At Lutheran Medical Center.
At Lutheran. Okay.
Yeah.
Yeah, great. Thank you so much for adding that. Any other questions or comments? Okay. All right, the role of nursing. I've kind of alluded to this a number of times about how we're going to participate in this other than just being the drug pushers, okay? So the more you can learn about this whole process, the better you can educate your patients and your colleagues and your physicians. That ASTEP guidelines right from the beginning is such a great document. I love it. It's not that long. It's maybe 20 pages, and I geek out on that kind of stuff, so if you don't, that's okay. But work with the physicians. I know this is what nursing does, right? We work with physicians. We suggest things to them. We come to them with feedback about how things are going with our patients. Be proactive with the patient. We even had because when we switched about a year ago to this, all the nurses wanted us to put a sign out in the ER that says, you know, we're reducing our narcotics. Management didn't think too highly of that. It was felt to be an EMTALA violation. But you do want to approach your patients and just say we're trying some new therapies. They may expect narcotics right off the bat, and you just have to sell them on it and see how it goes. But being a patient advocate, as we're trained to do, is going to be your way through this. Talk about realistic pain goals, as I said before. You want to make them feel more comfortable, less pain, but not pain-free. We're going to talk about scripting here in a minute. Oh, it's right there. Well, I think there's another slide on scripting. And promoting increasing comfort. And we're going away at my hospital from this 1 to 10 scale. As Dr. Stater has said, it's very unscientific. We're using low, moderate, and severe as our charting now. And I think there's something to do with Medicare reimbursement that they do require a number. But we're going more along the patient's descriptors of the pain and not just that 10 scale. And a lot of our patients have already been trained to give you that 10 scale right off the bat. But I want you to think about it as mild, moderate, and severe. severe pain, we're going to go to the narcotics a little more quickly, perhaps. Moderate pain is a really big zone of working with the altos to try and resolve that, make them more comfortable, have them less pain. Minor pain is probably pretty easily treated, as we know. You guys have any questions on that? Okay. All right.
I know.
We're talking about mild, moderate, severe now as well. And do you have definitions for that, or is it more subjective? Do you have
There are some definitions. I don't offhand know what they are, but there are some descriptors. But it's a little more fuzzy. It's not as, it's what the patient says it is. And then I think we have some nonverbal cues as well. Yeah. Okay. Thank you. Anyone else?
This is one thing that I've always been curious about, and many of our patients come in who use marijuana as well. So they're using opioids and marijuana. So how does that play into altos? And is there if somebody's a chronic marijuana user, anything that's more effective, less effective?
Oh, well, the narcotics would be more effective because they're not taking them, per se, right? I mean, if you're a narcotic beginner, novice, right, they'll work, they're more effective. But I have read completely outside of this that the narcotic use in the cannabis states is going down because people are using it.
That's what I think too.
They have
Yeah.
more access, and it's easier. It's easier to get marijuana now than it is to get narcotics, probably. So, it's legal. I don't know about the cost, but this is not going to interfere. So, marijuana use is not going to interfere in the use of the altos. Is that your question?
Yeah, or if
was?
there's
Okay.
if you've seen any effect, or if less effect or more effect. So maybe it'd be more effective if they come in and they're using marijuana.
No, what I said was narcotics would be more effective.
Right.
We are still going to try the altos.
Yeah.
Okay.
But it might work they might be more receptive to that even.
Yeah,
Who knows?
I don't know. I can't speak to that. I'm sorry. I'm not an expert in marijuana. Okay. Anyone else? Great questions. Thank you. Keep them coming. All right. So I know when I first heard about this, I had my impression. Now I've sort of been through it. What do you guys see as the barriers? What are your first impressions as things are going to hold you up? All right. Thanks for your patience with the mics. He had a question too.
I just think the biggest barrier is that discussion with patients because, and changing, it's the whole paradigm shift, changing their expectations and having the time to talk to them about all of this. It's going to be difficult.
Yes, it is, but
And there's time pressure in the ED, and there's,
yes, that's correct. This is challenging.
Yeah, and
If
that
you want an easy
discussion
career, this is not
it.
it, right? Yeah.
I think there's going to be some fear from nurses about ketamine because there's been so much discussion about scope and if that's within their scope, if it's out of their scope. So I think that's going to take some extra
Yes, thank you.
education.
And we're going to talk about this later, but protocol revision is a big part of this. You can't do this, as Dr. Stater said, without top to bottom buy-in. Your protocols are going to all have to be rewritten to reflect that pain dose of ketamine. And just the protocol or your guidelines will just simply say that no special monitoring is needed for that dose range. If it's for conscious sedation, that's a whole other ball of wax. And just people really need to understand the difference between those two dosing. Great point. You had something, sir, you wanted to say?
She pretty much stated what I was going to say too.
Okay.
It's going to be a patient population that's going to be a little bit on the trial and error part of this. Again, the other part would be the doctor's compliance and going along with this.
Yes, so he said the doctor's compliance and going along with this. One of my favorite physicians in the ER, I was very surprised to hear him say, no one's going to tell me how to practice medicine. So I was a little taken aback because he reads literature. He's always bringing new practices to the ER. So I was a little disappointed, but I think he's kind of come around. As I said before, you're going to have early adopters, middle adopters, and late adopters. And what they've started doing in our ER is now they're tracking the MEU units per physician. So they're, as a peer group, they're now kind of rating themselves as to who's the candy man and who's the alto man, alto hero or whatever. And so that will pull along the late adopters. And for you managers and directors, I would suggest that you bring this idea to your physician group. Our physician group is not hospital employed. They're a separate group that's contracted, so we don't have a lot of control over them per se. But they've recognized this issue that some physicians were right on board with the altos, some were not so much. And I just think that peer pressure of knowing that you're giving more narcotics than anyone else in the ER is going to kind of self-moderate that. There'd be very few people that would kind of dig in their heels and just say, I'm not going to change. It's an excellent perspective, and yes, some physicians are more on it than others. I had a renal patient that was being taken care of by one of our PAs, and he didn't attend the initial training, so he wasn't thinking this way. And I was really trying to get a lidocaine drip started on this lady, and it took me an hour of arguing with him, and he finally relented. But she had been admitted to a non-cardiac floor, so we couldn't do it because she would have needed to be monitored. But again, like everything we do, right? It's we're going to do what we think is right and move forward from there. Great question.
I think for more on the barriers, you have to have consistency. You have to have consistency with your doctors and your nurses on how to treat those patients. And that seems to be one of our biggest things, because we have some nurses who just, they can't tell someone no. Or they can't, if the patient's like, I just want to have my Dilaudid. The usual thing is, I need that medicine that starts with the D, duh, duh, duh. And so they give it to them, whereas, and there's some of us, who are more, I guess, firm. And it's hard. It's hard to get that. We're working on that, and we have a lot of meetings where we're just open about that and bring it up.
Yeah, are you a manager? Or
No,
you're
I don't
you're
want to be a manager. I'm a staff nurse.
Staff nurse, okay.
But this is kind of my passion. I've worked at our hospital for over 20 years, but I just got my nursing degree about 8 years ago, and this population of patient that's coming into our ER has skyrocketed, and it's disappointing and it's hard, and
Yeah.
we have to do something to help it.
Well, some of the scripting we're going to talk
Yes.
about is, hey, let's try something. Let's face it, some patients are bound and determined to get narcotics. That's what they came in for. They won't leave without it. And they're probably going to get some. But that's going to happen. But what we're trying to do is reduce the amount that we give out, the amount that we use. And if you read the ACIP guidelines, it says in there that the vast majority of addicts start with a prescription. So they start with medically prescribed narcotics. So I know I have a couple teenagers. If they're in the ER and I can avoid having them feel what it is like to have that narcotic, I'm gonna do that. I'm gonna not push for 2 morphine, because they may like it, and then 10 years from now they may go, oh, I really like that narcotic, right? We just don't want to introduce it. So there's some patients, right? It's almost too late. Or as Don said, you've got the patients who are being, we forget a lot of this, they're being abandoned by their physicians. They've been on narcotics for years and years and years. Now their physician is like, ooh, now I'm kind of liable if something happens. So they either kick them out as a patient, or they cut their dosage, or they cut their prescriptions. And now that patient is suffering because they're in withdrawal. We have a group of physicians that we had a pain clinic, and then the pain clinic collapsed for some reason, and then we have a group of physicians who are now starting to work in this area. And so those patients need to be directed to a specialist, a pain specialist. You can treat them maybe with a small dose of a narcotic, but if you can refer them, if you can find somebody, primary or a pain specialist or a rheumatologist seem to be really interested in this. If you can get a good referral for them, then you can maybe keep them from coming back and back. But in the emergency room, we're not going to be able to do much for them, though. Thank you.
Chris, I have one barrier that's going to be a brand new barrier that is coming out. And I don't know if any of you know about the HQIP measures, which are the Healthcare Quality Improvement Incentive. So it's a paid value-based purchasing, so you will get paid for these measures. As of 2019, 2 attestation measures that are specifically for the ED are coming out of the Alto checklist that you have. So EDs will have to show that they are at least implementing a portion of that specific Alto checklist, the one that you've seen. The second one is that you will have to attest that you have a point person, pharmacy and data, for the Alto program. So EDs are going to start to be given dollars for incentivized for implementing an Alto program, and it is based on this specific program. So we had a doctor actually last week write an email to CHA, and their hospital CEO was very angry, saying, "I can't believe," and his words were, "you bellied up to the bar for payment." And he was very, very angry about that. And it's not, and he was actually saying, well, we didn't even start this problem. You ought to go to the PCPs where they're the pill mill doctors. That's how angry he was. And it's not about that. What it's about is let's do the right thing for the patient. So these measures are not in place yet, but just so that you know as nurses that is coming down so that you'll be able to speak with your doctor. It's not about Joint Commission. It's not about regulatory, right? It's about doing the right thing for our patients, because the bottom line is, the question to the doctor is, well, which one of these treatments do you want to take away, right? Do you not want to do these treatments? Doesn't have anything to do. If you're doing the right thing for your patient, doesn't matter about the regulatory guidelines. So I just want you to know that's coming down the pipe here, so just be aware. Okay? Thanks.
Oh, thank you.
So
question back
I
here.
totally agree that this is the right place to start, definitely, and we'll completely be on board, and we can't solve world hunger overnight. But I wonder if you have had any experience with how this transitions into a hospitalist group, or 83% of our admissions come through our emergency department, and that may be unusual, but I can see this is going to be a big gap to
Right.
fill if we treat one way and then really they just need to survive the ED to get to the hospitalist, and then they'll get what they need.
Yeah,
So
excellent,
have you
excellent
had
observation.
experience with that?
Well,
or?
yes, immediately, right, in our first couple months, the floor nurses are like, ketamine, blah! They're getting these patients who got ketamine in the ER, and then they're receiving them up on the floors. So we had to put together pretty quickly some education for the floor nursing, that was a pain dose of ketamine, and so on. So we're in the process of working this upstairs, as it were, and the hospitalists are certainly aware of what we're doing. I don't know how much they're using it. I don't work with the floors directly that often in that regard. So, we're also going to look very disjointed if we're not approaching this as a facility the same way. You're absolutely correct. That's 100%. She said we're going to look disjointed if we're not coordinated as a facility. And you'll just need to bring this to the management and say, hey, we're doing this great thing in the ER, and we should be doing it upstairs too.
Just from a CHA perspective, just so that you know, now that this program is running out, I just said to Chris a few minutes ago, strategically, we are looking at what's the next step. And there have been, we've been kicking around, is it the EMS side? Because EMS needs to be brought into this. Or is it hospitalists, or is it both, or is it a orthopedic surgical line? So all of those need to be addressed, because hospitalists are turned over, as you said, into the inpatient setting. So we've had interest from all of that, those areas. So stay tuned, because CHA will be involved strategically in one of those areas. So it's not like we're dropping the ball on this.
Great, thank you so much. Anybody else? Yeah.
I'm from a
Hi.
rural hospital, and in the ED, if we had this program going, I think it would be difficult if we had to transfer patients to other facilities that are not involved in this program, and we're using these same medications, and then they do something completely different. We send them to all different hospitals in
You're
our
right.
area.
More and more hospitals are coming on board. We started with 10 last year, and then I don't know how many more this year. The goal, I think, was 70 more, Diane, this
The
year?
goal is 100% of the EDs will be
100%.
trained. We have This is the first one. We have 7 more sessions around the state, train the trainer programs in rural hospitals, rural areas of Colorado, and then the last one will be in Colorado Springs. So most of the training sessions are in the rural parts of the state. So stay tuned to that. You'll be getting more information about where those trainings are going to be taking place.
You're absolutely correct that that's an issue. One of the pilot hospitals was up in Sterling, up in the very corner of Colorado, and so once they started this program, all the other hospitals like Cheyenne and the other nearby hospitals actually called them and say, what are you guys doing? Because they were getting, all the narcotic seekers learned they couldn't get it at that hospital, so they were shopping around. And they even, the manager there told me that the patients would actually wait in the parking lot to see which physician was working, because they would know which of the physicians would give them narcotics and which wouldn't. So yes, that's a problem, but I think pretty soon, the more people that get on board, that'll just be less and less of an issue, though. Okay, yeah, we have 2 here.
Is there a way that we could start an education sheet of opioid addiction for our patients, that we could start proactive, even as a parent, when they come in? An example would be, I don't know that a lot of parents realize that a primary cause of addiction is coming from our children who get teeth pulled because they're given Percocet. And that's not something that we can control in our departments, but if we're giving that education in our emergency departments, it would bring a lot of awareness.
Yes, and I counsel people all the time that I will straight up say narcotics are super addictive, just be careful. I mean, when I give people prescriptions, I'll say, you know, try not to, don't use this all if you don't have to, right? And when you're done with it, throw it away. It's just basic safety. I mean, that outreach, I think, you would just work that into your workflow. Were you thinking of something more specific?
Yeah, maybe just an education sheet that we could standardize.
Oh, sure.
For all of us, a standardized opioid education sheet for every ER that goes with this program that is facts about opioid addiction.
We developed a patient education sheet. We have a patient educator at Boulder, and so she developed a Alto sheet for the patients, and so we give that out pretty commonly. Let's say you're trying to introduce this concept to a patient and they're not getting it, you might actually give them the patient information sheet while you go, I don't know, get their drugs or leave the room or something. They might have time to review it. So yeah, and then we do things like click it and ticket. Maybe you guys are doing that, where you hand out seatbelt safety stuff periodically, and that could be part of it.
Would you share that, Chris? If we could stick that on the website so that folks could get that, we could.
Yes.
Yeah. So we will develop these resources. We'll put those on the website. We have sample policies. We can share those on the web. The goal is to get you the materials you need. The Colorado Consortium for Prescription Drug Abuse Prevention also has a lot of information like that, so we have that on our website. One quick thing I do want to share is that you cannot have signage in your emergency room. You cannot have it in patient rooms that you are trying an alternative to opioid program. That's a potential EMTALA violation, so you have to be really careful. I get lots of calls about that. Can we hang signage? Can you send us signage? The reason for that is until they are triaged, you don't know what's wrong with them. So you have to be really careful about hanging any kind of signage that we are trying new evidence-based, we are treating your pain differently, anything that would indicate to a patient that you may not be using opioids. Okay, so be careful about that.
Yes, sir.
Chris, can you talk about your strategy for rolling out nursing education? I know on one of your slides you listed topics, but be interested in hearing.
I did write an education plan, which we can forward to you if you like. The strategy that was used last year was they had nurses from the Emergency Nursing Association come and do a talk similar to this. The reason you guys are here today is we're hoping that you're going to go back to your hospital and do this. You're going to do some sort of education. You can provide printed materials. You can send out emails just introducing the concept. I mean, there's different strategies. Session is being recorded that you would have available to you to have your nurses view. Am I getting to your question, or?
Yes, thank you for that. I know that you talked about the importance of scripting, and I'm wondering if that came into play on your education rollout, because I think that's an important component.
It is. It's a very important, and going to that consistency amongst the providers and the nurses to try and get them all on the same page. As Don said, in his ER, everyone is now on board, and so the nurses, everyone's talking the same language. That's not going to happen right away. But the more education that you can do, the better. So I would, multimodal as an educator myself, printed material, offer them a video to watch, offer them a class to go to. You can make a PowerPoint presentation, through your learning management system. There's a lot of different things that you can do. And I think the more ways that you hit this, the better, rather than just like, here's an email, right? It's probably not sufficient. Great, thanks. Oh, wait, can you just repeat that?
Are these the PowerPoint from this morning, this PowerPoint, and the physician ones that we're not in right now, are those going to be available on the website?
Yes, they'll be on the website?
Yeah, they're already there.
Okay.
So I'd like to stress that this particular program is a train the trainer program. So anybody can come, but the goal is for you to appoint in your facility a specific trainer. And that trainer then is assigned to go back and train your nurses. Okay? Just like we have a physician point person to go back and train your physicians. Now, you may decide to assign a couple of nurses, but it's really key to have a point person go back and consistency in training the nurses. So an educator, whoever's going to do that, these PowerPoints that are there are specifically designed for you to go back, set up the education plan that Chris has, and go back. There is a nursing toolkit along with the PowerPoint presentation that you use to set up a very specific train the trainer program. We have, Chris, your newsletter inserts. There are some other tools there, and Chris is available for you to call.
Sure, day or night. I have business cards. If anyone wants my email, come up after. I'll give you, and I'll be happy to help you with any of those questions. Anyone else? This is why it's so important that you ask these questions here and now, so that you feel comfortable to take this
Chris,
back.
in your ED, did you implement policies that regulate the number of days worth of opioids that could be prescribed? And did you also do anything from a policy standpoint regarding replacing lost or stolen prescriptions?
It's all provider dependent. As you might guess, providers would kind of balk at some sort of limit to what they could do. We generally are not replacing lost narcotics, okay? My experience, I might give them a couple, like 2 or 3 Percocets, and then say, call your doctor, whoever originally prescribed it. But we're not just taking them at their word and replacing lost narcotics. And there is no limit at what the providers, but the way the culture is changing, I think if a provider gives somebody 100 Percocets and they overdose, they're starting probably to be a little bit liable for that, for doing that, given what they now know about the opioid epidemic and overdoses. So I'm seeing the providers vastly limiting the prescription numbers. They're giving 5, 7 Percocets instead of 20. Just what they think, like Don said about the 3 days, right? Just enough to get them through those 3 days. And then they can see their orthopedist by that time, and if they want to if that doctor wants to provide more narcotics, then they can get them that way. But yeah, it's provider dependent, but the more information they have, the more they're going to make the right decision. So great question, thank you.
There is legislation that has just been introduced, and I believe it's passed, if I'm not, that does limit provider prescribing, and I think it's 7 Yeah, 1 week. I think that is correct. All that information about legislation and the bills that have been passed is also on the CHA website. So if you want to go in there, there's a whole bunch of information. There was an interim opioid committee that went through the entire summer. There were 6 bills that were sent up. I believe 5 of them passed. I'm not quite sure. But anyway, all that information is on there. So feel free to go ahead and look at CHA website as well. Do we want to move on to all the rest of your great stuff?
Well, this is such great discussion, though. I mean, thank you guys for participating. It's kind of lonely to stand up here and just talk. So anybody else? Feel free to raise your hand if you have further questions. So I did a survey, SurveyMonkey, of some of the pilot hospitals in preparation for this new phase of the project. And these are some of the barriers that the nurses actually found, that the patients do not understand the program. So that's up to us to educate them. And then provider buy-in. As we've discussed, there's a variability in how much the providers are going to buy into this. And then this is the biggest barrier is these chronic pain patients who really all they want is their narcotics. And sometimes they're going to get them. But as the culture changes, as our behavior changes, it'll become more and more difficult for them just to come in and ask for a dose of narcotic and get it without having a long conversation with a provider, perhaps. All right, so as I've said before, this is some scripting, and the toolkit that Diane referred to does have this scripting in there. We want to control pain, not eliminate pain. We're trying to make patients more comfortable. And that's really it. I mean, this is not rocket science, the scripting. It's pretty simple. Those 2 concepts right there will get you through probably 80% of what you need to know for the patient. And when you have the nurse who's just can't say no, just offer them this as an option, right? Say, hey, we're going to try this alternative first to try to make you more comfortable and see how it goes. You kind of have to be a little bit of a salesman on the program. And then this is just an example. The medications Toradol will help you your pain by reducing inflammation as one of those sort of pathways. All right, this is a huge piece. This is talked about inside the guidelines, is harm reduction. To me, this goes a lot to our changing attitudes about addicts. This goes to coaching addicts in how to be safer addicts, right? So we tend to fear that we're going to enable them. But some of the harm reduction strategies are, in fact, we developed a patient education sheet for this. Wash your hands before you inject. Use sterile water, not saliva, not tap water, which people will do, to inject. Save us a good vein, okay? If you have 5 great veins, just don't use that one that you know is good for us to rescue you. I don't have a whole, I'm not going to go through all the harm reduction, but this is, and this is for the patient who comes in either from an overdose or comes in for an abscess treatment that is, and you can just ask them, are you addicted to drugs? And if they say yes, then just say, do you know that you should wash your hands before you inject? You should wash your site with soap and water before you inject. You should not share needles, right? Not everybody knows that sharing needles will give you, blood-borne contaminant. To me, again, it's just a shift of attitude that you're going to treat this person, you're going to try and help them and treat them with some compassion. Not that you don't. Okay, that sounded bad. I'm sorry. That we show compassion for them, and then we counsel them on how to do better. Maybe counsel them to get Narcan. I tell patients to get Narcan. Physicians can write prescription for Narcan, and their insurance will pay for most of it. If they do that, you can buy it over the counter in Colorado. It costs, I think, $140, and it's 2 doses. So that's kind of unfortunate. Not a lot of people will probably pay $140, but you can counsel them to say, hey, you should carry Narcan. If you're going to be using, for you and the safety of you and your friends, you should carry Narcan. So that's my spiel about harm reduction. There's a little more detail in the guidelines, the ACEP guidelines, which I found to be really, really effective. Suboxone is a bit, is Suboxone listed there? No, it's not. Okay, never mind. Any questions on harm reduction? Yes, ma'am.
I don't have a question, but I do have We recently found a coupon that would work for Narcan, and
Oh,
I don't
great.
have it with me, but I can send it to you guys so that you can share it with everybody in here. It reduces the cost at Walgreens to like $10 for the patient instead of $150.
Is that something you can print off online, or?
Yeah, you can go online, print a bunch of them, but you have to print it. You can't actually recopy the coupon or it won't work. But Walgreens will
I'll have
copy it
to
and you can
look into
print
that.
as
Thank you.
many as you need.
Thank you.
So I'll send it to you guys so you can share it.
Yeah. Great. Any other comments or questions about harm reduction? All right, so let's talk a little bit about pain assessment. We're going back to that scripting of controlling pain, making you more comfortable, try to take your moderate pain to mild pain. And then reassessment within a reasonable time frame. Just make a bit of a contract with your patient and say, hey, we're going to try these medications and see how you feel in 30 minutes and reassess. And then, again, if the pain is not relieved, then you might move on to narcotics. This is some more information from the survey that I did. 93% of my colleagues approved of the program. I was very happy to see that. And then the headache one, 45% of the nurses said the headache was the most effective and valuable. And then the least effective was the extremity joint fracture. As you might expect, that's the probably very most acute type of pain. So again, nitrous oxide would be really helpful in that regard. We don't use it, and I don't think any of the pilot hospitals, Swedish might actually. Half of our patients, the nurses found to be supportive, and then they found the scripting to be really helpful, 68%. This slide is really not necessarily a nursing slide. This is a risk for addiction of any person, any member of the population. Physicians should have this on their radar when they are prescribing narcotics, although we've already seen that they're going to be limited in how much narcotics they can prescribe. On the left here, you're going to see a list of characteristics for people that have very high potential for abuse, and then the comorbidities that they should be assessed for. So I just think it's maybe if we know something about our patient that we want to share with the physician, like they have a history, a mental health history that the physician might not be aware of, it would be good for us just to point that out. This is more of an FYI. Although in your personal lives, if you know people that have 2 or 3 of those indicators on the left, then you should know that they have a much higher proclivity for abuse, to be abusers. This refers to medication-assisted treatment. It's inpatient treatment or medication assisted with Suboxone. As I understand, Suboxone requires a special certification as a physician to prescribe, and so that's a limiting factor that we're having a lot of trouble with. Suboxone is very effective at treating addiction. These are just some rhetorical kind of questions. Do you all do ESPERT screenings? And do you have a mechanism to refer the patient when they score positive? You don't have to answer. It's just if you don't, then you might want to look at doing that. Does anybody not know what ESPERT is? It's a, oh God, something. It's an abuse assessment. Anybody know what it stands for? Substance. Brief intervention, referral, and treatment. Thank you. For substance abuse, alcohol, and drugs. It's a series of questions that you ask the patient, and we ask it for all of our trauma patients. It's triggered as an assessment. We use Meditech, so it just triggers the assessment if their complaint is traumatic. And the questions are, how, do you drink alcohol? Do you ever have more than 5 drinks at one sitting? And how many drinks a week do you have? As you probably know, the limit for men is 14, and women, is it 7 or 8? So then you ask them, would you like referral to treatment? There's been some evidence that just addressing this with the patient and asking them point blank, how much alcohol do you drink, can get them starting to think about, maybe that's a little too much, or gee, maybe 20 drinks a week does sound like a lot. But you need a little bit of referral background. We use case management if they trigger positive. And then you can ask the patient if they want assistance with that, and they may say, yeah, I drink 10 beers every day, and I'm happy with that, and it's good to go. But it's a mechanism by which you can start catching some of these addicted patients. And then for the medication-assisted referral, do you know a physician who prescribes Suboxone? And, can you refer those patients to that physician or to that practice if there's a pain practice? Or some physicians will specialize in this area. And hopefully we'll be seeing more and more of them as we go. Okay, so we're going to talk about some of the steps. This has already been talked about, I think, in Dr. Stater's. If you're just looking at Alto, there's a lot of things you have to do. The director of nursing's got to be on board. I mean, you need that support all the way because you're going to be rewriting protocols and guidelines, and that's usually at the managerial or directorial level. And if they're not on board, this is not going to work. We got this right from our CEO, which was great. He's a ER physician. He got on board with this, and he just told the hospital, he said, we're doing this. So he told everybody, get on board, all the other physicians, and you really need that buy-in from every level. Quality improvements involved IT data support. Your e-charting is going to be reflected in the order sets. We now have an Alto order set which pulls up all the alternative medications and the appropriate doses. Those are a lot of back-channel things that have to be done. And then the pharmacy is going to be carrying possibly different formulations of medications, different concentrations, maybe of the ketamine. Probably not. You probably have 2 concentrations that will be sufficient, but the lidocaine patches, we had to get them, and so on. Here's just some examples of the ketamine we've talked about, having a pain dosing scale instead of a sedation dosing scale. The 0.25. Now, this slide deck sometimes says 0.2 and sometimes says 0.25. I can't explain that, but okay, it's going to be arranged in there. And then you want to identify any high-risk medications like lidocaine, whether if it goes over this amount that's listed there, right? You just need a new policy that is going to protect the nurses and guide the care. Any questions on that? They're talking about the physician computer order entry there, the CPOE, and those order sets have to be adjusted. I forgot about smart pumps, yeah. So all of our smart pumps, if you have smart pumps, will have to have some of the dose ranges were not in there. They had to be programmed in. Does anybody have any doubt about what I'm talking about, smart pumps? Okay, not all hospitals have them, but I'll just explain briefly. Whenever you're going to hang a medication, you put the drug in the library, you pull it up from the library of the pump, and then you're offered some dose ranges. And if you program the pump to go outside those ranges of administration, it will tell you that's too much or too little. So those will need to be adjusted if you use them as well. Ours are Wi-Fi connected, which is great. They can just push out a change, but that's a pharmacy thing. Data collection, not my thing, but obviously the more data you can collect, the better. It would be nice for you to know that you are using your Altos better. I don't think data collection is required to participate in this program, but it really will help CHA and this entire state do better. The patient satisfaction, as I stated earlier, there was no change in the HCAHPS scores. At my hospital, the HCAHPS scores went up from 40-something to 50 plus or something. So that was a big win that the patient satisfaction scores didn't go down. I think there was a fear that would happen, but it did not happen. So patients, they like it. And these are all the partners that we're working with. And we need to thank Video, Tri-County Overdose Prevention Partnership for providing money for the video for this session. CHA.com/Alto is going to be your portal for more information. If there's anything you can't find, feel free to email me or anyone at CHA for more specific information, or if you can't find something. That's my, I'm the education chair this year for the ENA, that's my address for them. But I'll give you my other professional email if anyone wants it. Thank you so much for coming. Thank you for what you do. Thank you for participating, and I hope you guys learned something good today. Thank you.